another AHPBA Grand Rounds webinar. I think there are very few good things COVID has done for us, but I think it's inspired us to do these types of webinars, which has been very successful. This one is sponsored by the International Relations Committee, and Federico Osejo is going to be the moderator, and we're going to really have a nice, really diverse group of surgeons and medical oncologists throughout the Americas, really present some interesting stuff, and I'll let Federico moderate. Welcome, everybody.
Thank you so much, Michael, for your support. Thank you, Jill and Malia, for your help to setting this up. Thank you, the speakers and the panelists. So we have an hour and a half with 3 sessions to go over the program. So we have about 25 to 28 minutes to cover the presentation from the speakers, including 5 to 10 minutes where the panelists will get engaged in the discussion and also address questions that may arise from the audience. So we're going to start with the first session of the program, which is a case of a minimally invasive liver surgery. And the speaker and the moderator will be my colleague and friend and our director of the laparoscopic liver program here at Cleveland Clinic, David Wong. And the panelist will be Dr. Alice Way from Memorial Sloan Kettering, New York, Dr. Claudius Conrad from St. Elizabeth's Medical Center in Boston, and Dr. Iswanto Sukandi from the Advent Health System in Tampa. So thank you so much, and let's have it started. David.
Federico, thanks so much for the kind introduction. Today I have a case that I have prepared. It's a case that we usually don't discuss much in big conferences. So I thought it would be nice to have this kind of discussion in a more small group of a webinar style program. So I'll go ahead and share my slides. Can you guys see my slide? So yeah. It's a case of huge hemangioma on a Jehovah's Witness patient that had been referred to me, whether it would be feasible to do a laparoscopic liver resection or not. And I thought it would be nice to discuss this case from 2 perspectives. One, for how can we salvage some blood and have no transfusion set up in OR during a liver resection, and secondly, what would be some of the strategies that you can have that is specific for hemangiomas in a laparoscopic liver setting. So I'd like to have a very interactive discussion with our panelists. So anytime I'm going to ask questions, please feel free to ask questions so it can be a more interactive discussion. So the history of the patient, she's a 46-year-old female patient. Again, she's a Jehovah's Witness case. She had a hepatic hemangioma that initially was detected 15 years ago at a 2.0 centimeter in size. And she didn't have any symptoms back then. She was just followed up maybe annually or biannually. And by early this year, she started to have some vague abdominal symptoms, discomfort, so she did another MRI CT image study, and she found that the tumor had grown substantially during those 15 years to more than 10 centimeters. She started to also have early satiety. Upon physical examination, you could visibly see the abdominal mass in her epigastrium. Around that mass lesion, it was slightly tender. But overall, in other areas of the abdomen, it was really not that much tenderness. She also happened to have a uterine myoma, and with some profuse bleeding on menstrual cycle. And she wanted to have the hysterectomy done simultaneously. So that was another challenge in a Jehovah's Witness case. So in these kind of settings, I would first like to ask the questions of how you guys would plan a surgery. Would you plan for uterine myoma and the liver resection together, or would you prefer to do it separately? Anyone from the panelists?
Do you have any imaging? I guess
Okay, sorry. That would be helpful. Yeah. So this is her CT. So it's segment 4. It's a huge hemangioma. It's a huge hemangioma, pedunculated type. There's the mass at the tip of the hemangioma comes almost close to an umbilical area.
So what's your, David, your strategy for these? A enucleation?
Yeah, so first, I mean, would you do the hysterectomy together or would you do it separately? Would be the first question.
Alice, you have a similar case like this recently. What would you do?
I certainly don't have I think you could do it simultaneously. I think the planning would have to be whether or not the ports were the same or different for the two, for the right upper or mid-abdomen versus pelvic approach, whether you want to do laparoscopically versus robotic assisted. And I guess, take one step back is whether or not, with hemangiomas, the indications for surgery is sometimes, there isn't an oncologic reason for it. Really would have to be driven by how symptomatic she is.
So you would go for simultaneous.
Yeah, I think it would be fine. If she made indications for surgery, I wouldn't have a problem with it being simultaneous. I'd probably talk to that again. I would probably talk to gynecologists to ask them what their port sites would be, so we could sort of pick the ports that would work the best for both of us, both services.
If I can add, in our program, we actually do a lot of combined surgery, liver and colorectal, actually colorectal surgery. And in this case, I feel like the hemangioma is almost like is hanging off segment 4B. I could not see the vasculature, but it looks like it's quite exophytic. I know it's big, but it's quite exophytic. I agree with what Alice says, and port placement needs to be talked about. But I've moved a lot of ports before. It means if the colorectal has to do a certain position and it doesn't work for me, I pull out the port, I put the stitch, I move the port. I don't think it's a problem.
Guys, I think he's trying to ask about this in a Jehovah's Witness. I mean, I don't know how many of you dealt with many Jehovah's Witnesses, but if this lady bleeds, she'll die if she really refuses surgery. So you're increasing your surgical exposure, so to speak.
Yeah.
I think without a Jehovah's Witness, there would be zero discussion about whether to do this together. I think extra ports don't mean a thing. Claudius, I know you never lose blood, but what if you lost 500 cc's during this case somehow? Would you go ahead with the hysterectomy, or would you tell your gynecologist to stay away?
I think, Mike, you point to all the issues with this case, and Alice already talked about the indication. I mean, to do this case in a Jehovah's Witness, I really want to have strong symptom pressure, and size typically doesn't correlate with symptom pressure. You can have humongous hemangiomas that reach the pelvis and the patient is minimally symptomatic. So the patient really has to have strong symptom pressure. And yeah, I'm a big fan of separating out surgeries. I think I would insist on starting with the liver resection, and if that goes perfectly, I may consider including the hysterectomy. But in the context of this specific case, I would try to do the safest thing possible. Maybe start with the liver. If it goes perfectly, consider moving forward with the hysterectomy. Yeah, I also agree. There's not a ton of parenchymal transection there. From what I can tell from the CT scan. And I think the indication is the main challenge of this case. It's not a technical challenge, I think.
Yeah, thanks so much for your input, everyone. So I had the similar questions as Michael said. If it wasn't a Jehovah in this case, I mean, really not that much discussion. But so the way we decided to do with my gynecologist was, okay, since she requested the liver part be done first, I'll be doing that part first, and if everything goes on well, he'll come in and do the remaining part. If I end up bleeding too much, then we decided to separate the operation and take two different operations at the same time. About the size, maximum size, as Claudia said, I don't think there's really a maximum size indication. Do you guys consider anything about increase percentage of size per year in hemangiomas? Because sometimes I run into an issue in which they have mild symptoms and you can see it coming, but then if it grows too much, it's probably that you're not going to be able to do it laparoscopically. In that situation, what would you guys do? If it goes larger than that, it's probably going to be open. If it's the size that it's right now, you can take it laparoscopically. Would you take them laparoscopically now, or would you wait and see? And if it grows more, would you take them open?
I would wait. I think just because you can do it minimally invasively, it's not really a strong indication for me. I think another aspect would be Kaspar-Merit syndrome. If they have consumptive thrombocytopenia, that would be another aspect. I just want to point out to one interesting thing. We published on partial splenectomy, and there's actually a group of Jehovah's Witnesses in Cuba who screened the medical literature for blood-saving procedures. So after we published this paper, we got this nice prayer from them and an invitation to Cuba to join them at a conference where they talk just about medical procedures that are blood-saving for Jehovah's Witnesses. So I think they would appreciate our AHPBA grand rounds today focused on this important topic.
I do agree with you that, I mean, I tend to be very conservative. Obviously, there is no malignancy risk for these lesions, and unless they truly have symptoms, generally of Kaiser-Merrick or high output cardiac failure, I generally would not. I would generally not operate on them. You know, I think you could make the case in somebody who has Jehovah's Witnesses, they might be getting thrombocytopenia and Kaiser-Merrick and anemia related to that. So maybe there's a case, but and usually symptoms are minimal at most. You know, I mean, I've had patients with them 25 centimeters in size. They eat and drink perfectly fine, even though they see a bump on their skin.
Right.
Can I point out the symptoms things? I would say those large ones are posterior in the right liver, and they can get huge and people don't notice anything. This is a classic one that causes symptoms, hanging off the left liver in the front of the abdomen. I very much believe this was symptomatic. And
they can twist on themselves, right?
Yeah, sitting right on top of the stomach.
You know, I think looking at this CAT scan, and David said it's symptomatic. I think I would believe that this is symptomatic. And we actually do a lot of Jehovah's Witness in Tampa because we are a Jehovah's Witness program for HPB surgery as well. I like all of the colleagues here, I try to be conservative, and I really ask for the patient whether this is the problem or not. Because sometimes patient have hemangioma big, and then the problem is the gallbladder is causing the problem. It's not, you know. But if, you know, more than 10 centimeter and, you know, symptomatic is probably.
Specific location.
Yeah.
Okay. The patient had a normal CBC, had a normal liver enzyme, but had a D-dimer of 7,710. What do you guys think? If she did not have any symptoms, would you guys go for surgery or not?
No surgery unless strong symptoms.
Yeah. Especially in this case.
Yeah, I never use D-dimer as well. I mean, I go by symptoms and size.
If she had a normal CBC, would you take her for resection?
I wouldn't believe a hemangioma this size could cause a real Kaspar-Merit, personally.
Yeah.
Okay.
Exceedingly rare, and they have to be huge.
Yeah, I mean, usually it's in the 20 centimeter range rather than the 10.
Okay, and what kind of liver resection, as Federico was asking, would you guys consider for this case? A wedge resection, enucleation, or left hepatectomy?
Depends a little bit on the subtype. For this specific, I think it seems like a regular type hemangioma, and I think enucleation would be appropriate.
I would go for enucleation as well. I mean, I don't think, doing a left hepatectomy for this is, I think, is a wrong move. So enucleation should be a way to go.
Do you think there are people out there who would do a left hepatectomy for this thing hanging off of segment 4?
I don't think so.
I think they might be confusing cancer and hemangioma.
No, but as Claudia said, I think it depends on what kind of hemangioma you have. There's some hemangiomas you don't have good,
Delineation.
yeah, delineation between the normal liver and not, and those are really difficult to enucleate. And I would say in those cases, I'll go for left hepatectomy instead of just doing, trying to wedge or enucleate.
Well, I think the principle is just a clear margin. I guess that's what we're all saying. I mean, the patient I just did recently with that Mike was referring to, that like has total body and total liver hemangiomatosis, and we basically enucleated this 23-centimeter lesion, but left just went through the rest, So.
And I would submit you don't even need a negative margin. It's just
You just need you just need to be out of the pool of blood to reduce your risk of.
Yeah, this is a technical issue, right? It's the best way to get the thing out. Who cares about the margin? This is
It bleeds more.
But if you don't have good margin, don't you think left hepatectomy might give a better clean resection rather than going right in between the hemangioma and the liver?
no.
Not for this case though. I mean, this case clearly, the rest of the left hepatic lobe is good.
Okay, I brought you another case here.
Oh, but what did you do in the first case though?
We'll talk about that. I have a video.
He's playing with us.
Yeah, the suspension is killing me.
I mean, I think the principle is that you don't want to be within that big pool of hemangioma, because then you have issues of controlling bleeding as you go through and at the end. Right? So you be outside of that lagoon of blood.
Mm-hmm.
And the walls of these tend to be pretty tough. They're not like soft things.
Right.
Yeah, for these ones, would you go for right or would you go for enucleation?
For this one, I would go for right hepatectomy.
Well, I think it's semantics. I mean, you would basically go with whatever can get it out.
I think an enucleation essentially is a right hepatectomy.
Yeah, that's what I mean. Like it's almost equivalent.
Yeah, but I think that in this case, if you plan for a formal right, when you take the right hepatic artery, this thing immediately shrinks.
Yeah.
And makes the operation easier, and so that's an important concept. Pringle taking the arterial inflow.
Absolutely.
It's great.
For this case, though, I think right hepatectomy is easier than enucleating this, because you see hepatectomy, your plane is much thinner, and then out of there you probably sacrifice 5-10% of extra parenchyma.
Well, once you get good inflow control, that thing is going to be much smaller.
Right.
Okay. Well, I think I like that the way this discussion is going.
There's a question in the chat that's a really good one. Would you like to embolize before resection? Anybody
I personally don't embolize before resection because I ligate the artery during the very early phase of the operation. Yeah. And while I do the resection, it's embolized.
Mm-hmm. Right.
In a sense. So I don't do and if you embolize, they usually have a lot of pain. It's really painful when you embolize a hemangioma.
As soon as you take the artery, that's your embolization there. I mean, your inflow obliteration arterial. So I agree. I wouldn't do it.
I would also make a joke that Leslie Bloomgart used to make in New York. Embolizing this is like, well, I'll say it in a nice way, urinating in the East River and expecting a high tide in Connecticut.
Good one.
It will refine arterial blood supply in about 5 seconds.
Agree.
Okay, anyone would take this case for open?
Which one, the big one?
Let's say the first one, the segment 4.
Claudius?
I think, there's not a ton of parenchymal transection here. I think this can be done well, minimally invasively, if you position yourself well. I think there may be issues with exposure and compliance of the abdominal wall and position yourself well. little bit atypical, I think, from how we would usually operate in segment 4B. You probably want to be on the side away from the hemangioma so you can come across segment 4B, but I think it's okay to do it lap or robotic, either one.
Joanto, robotic, right?
I would do this minimally invasively, and I would position the port from the left side. It means if I need to staple this, I want the staple to come from the left to the right. So in case shit happen, you know, in case patient, you know, which, you know, we have to be prepared because, you know,
you always have to be prepared for shit happening, for sure.
So, right. So,
do you have any preference on laparoscopic versus robotic in these kind of cases?
You know, I like to do this big case robotically. I think it's better for exposure, and the energy is a bit stronger. I think the electrocar is much stronger robotic than open.
I mean, I would say, I want to just be the devil's advocate for a moment. I think it's, I know the session is called laparoscopic liver resections or minimally invasive, but it would be very reasonable to do this open. I think particularly for the people on the call, I think if you're going to do it minimally invasively, and I think you've heard it from everybody, you have to be careful about the port placement because I think loss of domain is an issue just to plan for.
Yeah, I think every operation that's done minimally invasive is reasonable to do open. I mean, let's not get ahead of ourselves. I would say though, if you plan on a nice enucleation and really want to be in the correct place and not lose one drop of blood, a CUSA may come here very, very handy. I think that helps you to be right at that interface between liver parenchyma and hemangioma, and you should not lose any blood.
You know, that's a very good point. I was going to ask, you know, laparoscopic versus robotic, because with the robotic platform, you know, you have the sealer, but you don't have the CUSA. I mean, you could use the CUSA at the bedside, but, you know, it's difficult with the arms of the robot, right? So to that end, I agree with Claudius that the CUSA will give you that advantage and capacity to stay on the wall and, you know, do a finer dissection compared to the sealer of the robot. You know, if you do it laparoscopically versus
Does
robotic.
anyone use other method other than CUSA to go to enucleate the hemangioma? Because I do it differently. I'm a CUSA fan, but for hemangiomas, I do it a little bit differently. And I'll show you a video on it. But
yeah, I mean, crush, clamp, all parenchymal transection techniques are reasonable, but maybe in the context of a Jehovah's Witness and this being pretty big, and maybe you want to really, really make sure that the hysterectomy is completed with the same case. So I think it would be reasonable to get out your CUSA and use the CUSA in this case.
I just want to be clear. I've done many major liver resections on Jehovah's Witnesses with a clamp.
Yeah.
Yeah.
It's the technique that works for you,
Exactly.
whatever that is.
I mean, I think a vessel sealer is also a reasonable approach for this because you have to worry that there may be compressed normal liver beyond and that the patient may have leak after or bile leak beyond. And so, you know, you know, you don't have to worry about an oncologic margin. So I think also trying to get it out in a timely manner as safe is also another consideration. And certainly whatever works is fine. But I think that would be also reasonable. You know, I use that for polycystic livers. I always use ligature because I worry about bile leak after.
so if you do it robotically, do you use the ligature or do you use the harmonic?
Just a vessel sealer. I don't use mass harmonic because I don't think it's sealed well. I think vessel sealer will be the best. I've been using vessel sealer for hundreds of cases, and I use the crush clamp with the bipolar before I apply the vessel sealer. So I sort of crush clamp a little bit, sort of burn a little bit, and then once I know what it is, and then I change with the other arm to go for the vessel sealer. For this specific case, though, what I anticipate will be there will be a bridge between the inferior edge of the segment 4 and the big hanging hemangioma. I think it's important to be able to pass an instrument from dorsal to lift up those bridge. I think that will be the key. If the hemangioma start bleeding, you know, if you can lift up the bridge a little bit, I think that's gonna minimize your bleeding a lot.
For hemostasis, hemostatic maneuver, yeah.
Yeah.
Pull it up.
You have to lift up a bit, bleeding stop right away.
Good point.
Okay, just for the time's sake, the way I designed the port, this is what I usually do. But for this case, because the mass was here, I decided to take this down here in order to have enough room inside the abdominal cavity to go around the hemangioma to be able to get access. I did not do a left side approach. Looking in retrospect, I think that would be a really good approach. Any comments on this one?
Yeah, you know, I know you're very experienced minimally invasive surgeon, and you probably can get this out operating through the chest on this, but I think the problem is twofold if you have low ports. Number one, you're below the horizon of your plane. You're always working against this fulcrum, and your parenchymal transection plane is always behind the transverse colon or the stomach or that large hemangioma. That is one, and then the other is that it's kind of hard to bring your instruments around it. It's easier if your camera is in the middle and your instruments are there. And as you're putting the patient to reverse Trendelenburg, the hemangioma will provide counter traction for you. And I think another important aspect is to pull the umbilical fissure upwards and maybe even secure it to the abdominal wall, so you can do this open book approach. But I'm sure you can get this out with any port position with your big experience.
David, can I ask you a question about whether you would design the ports a bit differently, knowing that you can change the size of the lesion with some maneuvers, which you'll probably mention in a minute?
Yeah, I mean, the only thing I like to have the camera at the center, because I always do a French approach, and that's the way I just decided to go a little bit lower to not hit into the hemangioma, not have the hemangioma right in front of your face when you insert the camera. So that's why I put it more lower. Looking in retrospect, as I said, I think it would have not been bad to have a left side approach to have more room. And if you have the patient like right side down when you do a left side approach, you also gain some distance between the ports. And you also have a very good angle of attack, especially at the pedunculated area where that's, as you had discussed, the important part that we have to take care of. Okay, I'll move on. This is some of the topics that Claudius was talking about, but I think I'll just skip this part. Okay, I'll just because I think I'm over with the time. These are some of the methods I always do when I do laparoscopic in hemangioma. When I first start, I just do Pringle, and during my first Pringle, if it's a case where the hemangioma lies on the left, I get the left hepatic artery. If it's a case that this on the right, I get the right hepatic artery, and I bulldog clamp that artery. And then I let go the Pringle, and that artery is clamped throughout the operation. And by having that kind of approach, I think the hemangioma size decreases substantially, giving me more room to be able to resect. I always also routinely use a cell saver during surgery and after surgery. I'll show you a video that's after I take it, I cut the specimen inside, try to suck out as much blood as possible before taking it out. I think that's twofold advantage. You have a smaller size incision to take out the specimen. And then by using cell saver, I think I even had cases where the patient ended up having a higher hemoglobin post-op than preoperatively. So, I think it's a huge advantage, especially in a case like a Jehovah's Witness. Okay. This is the way, sometimes when it doesn't work, I have the bag here and I put it inside to suction out. This was like 20-something centimeter, and I just put a maybe 7 or 6 centimeter incision to take out the hemangioma out. Okay, and this is about the size that I took it out. This is the incision that, for the right huge hemangioma that I had.
Can I ask if you always leave a drain?
For major, yes. For minor, no. I'm still old-fashioned, so and I just don't like when I have to take the patient back for a PCV.
Sorry, PCV?
Percutaneous drainage.
Oh. But there's no proof that a drain prevents that.
No, it doesn't prevent, but no, you can prevent the additional, percutaneous drainage. Because I still have the old habits of practicing Korea. In Korea, patients go home at day 7, right? So you have the drain there as much as you want, and you take it out before the patient goes home, and you don't have to have any additional drains placed in case you have some bio leak.
Do you guys don't leave drains at long?
I haven't left a drain in almost 20 years.
I never left a drain as a fellow or as attending ever.
So
It's
no
it's
matter-
essentially a never event.
So no matter you do that.
Unless they're having biliary reconstruction.
Right.
So regardless.
I used to leave a drain as well, and maybe, but when I was in Pittsburgh, everybody get drains. But then when it came to practice, I did drains maybe 50 cases, and then I quit draining.
We should be clear, though, the level 1 evidence from randomized trials does not show any benefit to drains or decrease in IR interventions, just to be clear.
So Michael, even though it's let's say central lymphodectomy, you don't put drains?
No,
Unless they're having an HJ.
no. I mean, maybe 3 or 4% of them will need, something done for a bio leak. And I'm just not convinced the drain prevents that.
Okay.
For
Interesting.
you, Claudius.
Yeah, I want to be Switzerland here. We use some data from France. Michael, of course, correctly points out that there are several randomized controlled trials from Asia, from Europe, that have shown it probably doesn't make a difference. We do it based on 3 factors: blood loss more than 500 cc's, more than 8 cycles of chemotherapy, or bile leakage at time of surgery. And that is retrospective data that we apply. It's a little bit, chicken, but I think...
Oh, if there's bio leaking, that's a different story. If you can't control a small bio leak.
That's not routine drainage. That's selective drainage.
Yeah.
Right. So we have a selective drain policy.
David, are you going to mention the consent process for Jehovah's Witnesses? I think for the young people on this phone call, it's really critical. Maybe after your video. Sorry, go ahead.
No, actually, I don't have that. Just wanted to show some parts that I do. As I said, the way I do the approach for, you see here, it's huge. You don't get access to what you want to do. So the first thing I do is put a Pringle. And the way I do Pringle, I like to use my Chitwood Clamp. I think clamp is a little bit better than vessel loop. It's essentially a vascular clamp.
Oh, that's nice.
Nice.
What's that clamp? I like that. That's called a Chitwood clamp?
Chitwood DeBakey clamp. It's a vast surgery instrument.
Yeah.
If you have a hole in the IVC, it's really nice to control the bleeding.
We never get those.
So this clamp is better than the vessel loop or
Yes, I mean you can feel it. It clamps really well.
Got it.
I've always used vessel loops, but that looks really nice.
I think it's more effective.
Yeah.
Yeah.
So this is the way I do enucleation. With my bipolar, I activate and I spread it out. And I think the good thing about the bipolar is that like this kind of bleeding, it gets relatively well controlled.
Yeah, I would be a touch closer to the hemangioma even.
There's often a very nice plane right on the hemangioma.
Right.
Yeah, this is the wall of the hemangioma right here.
Yeah, I think you are on it. It's easy to get off it into the vessels in the liver.
Yeah, and this is the main inflow of the hemangioma.
Nice.
So I still have the Pringle maneuver while I do this. So I'm very time conscious about the Pringle time when I do a hemangioma, especially because I want to have things prepared before I release the Pringle. So this is probably the main inflow. And I divide it. But then here, I felt a little bit short of time and I had to let go my Pringle. And the same Chitwood,
Nice.
I applied it right here. so that the hemangioma would not inflate again. And then waited for 5 minutes and then crinkled again and proceeded.
That's nice.
Nice. Really nice.
Very nice.
Good
Very nice.
idea. Good idea.
I have to admit, instead of that big clamp, I probably would have just put a big stapler across that.
I was
Yeah,
gonna-
this is what I'm gonna do here now.
There you go.
So this is what I was saying earlier about lifting up. You know, if you pass and you lift up like that, you just go like that and be done.
So did you guys end up doing hysterectomy?
Yeah.
Yes, we ended up doing hysterectomy altogether. This is something really bad, but the cell saver bottle broke. So all the blood that I saved was not used.
Oh my God.
So this is what I routinely do. I open up the hemangioma and suck the blood out to make it smaller, so it can be, you know, taken out through the bag.
Very nice.
Federico, we have to keep moving,
Nice.
don't we? Because we have 3
Yeah.
cases.
Yes,
Nice.
David,
Okay.
you don't have it.
This is it.
Perfect. That was
David, that was great.
Nice case.
that was awesome.
Nice
Thank you,
discussion.
David. Yeah.
Great discussion.
Thanks for
David.
thanks for
Thank you.
sharing, David. Good
Thank
case.
you. Thank you, David.
Thank you.
Thank you, guys. So we'll move on to the second session. And for this, we have neoadjuvant approaches for borderline resectable HCC and cholangiocarcinoma. And the speaker will be Dr. Renuka Iyer from Roswell Park in Buffalo, New York. And as panelists, we have Dr. Ganesh Gunasekaran from Mount Sinai, New York, Dr. Ghassan Abu Alfa from Sloan Kettering, and Dr. Bassam Esfran from Cleveland Clinic. Renuka, thank you so much. It's your time.
Thank you so much. And let me try to share here. All right. I hope everyone can see the screen and hear me as well. So I'm going to try to cover 2 cases, and we'll maybe talk about them a little bit after each one. So the first one's an HCC case, a 73-year-old Caucasian male patient with this past medical and surgical history. Really no social history suggesting risk factors for hepatocellular cancer. And on his routine follow-up was found by his primary physician to have abnormal liver function tests that persisted. And so they did an ultrasound and saw a 6.7 centimeter space occupying lesion in the liver, which was not seen previously in a previous scan from a few years prior. They went ahead and did a CT, which showed this mass to be 6.9 by 7.1 centimeters. And they did a biopsy, both of the liver as well as this mass, and the results showed that there was a portal and bridging fibrosis, so really of unknown etiology, and the biopsy showed HCC. Here you see the images of the mass, the tumor. You see a large multi-segment right hepatic lobe LIRADS 5 mass. It abuts the right portal vein. No portal or tumor thrombus was identified, and initially it was thought this person would benefit from some neoadjuvant therapy. So at the time we had a clinical trial with sunitinib and chemoembolization, and he had that, and 2 months later was discussed after TACE. Post-embolization, as you can see, there is a large right hepatic lobe mass once again, now showing hyperdense foci consistent with the embolization, and no significant residual enhancement by CT. And what you see there at the periphery is not a mass, it's just a transient perfusion abnormality. He was offered surgery, and during that exploratory lab, he had a right triseg with a multifocal HCC. This was what the pathology finally showed: moderately differentiated tumor, negative margins, and he was placed at the time on surveillance. Unfortunately, the year after, about 7-8 months later, he was found to have a solitary recurrence in the liver. The scans showed this LIRADS 5 lesion in the left hepatic lobe, and we ablated it, and you can see the post-ablation imaging showing no residual enhancement, no viable tumor. This case is quite interesting also because he eventually developed a solitary metastatic nodule in his right hemithorax, for which we did palliative radiation, and it was still enhancing, still present, causing pain. So he had a chest wall resection of this mass, and 2 years later had a biopsy-proven recurrence in the right upper lobe, for which once again we did radiation, and now he's 14 years out, doing quite well. We don't see him anymore. I encourage the participants to send some questions if they have any questions, but I'll open this up for discussion with the panelists and ask both Ghassan and Bassam, who are on the panel here, what do you feel about the role of neoadjuvant TACE versus some of the newer immunotherapy combinations?
Well, I'm guessing that you're asking about in this setting of maybe not initially operable. I mean, it's good that you had a clinical trial. I think that should be a consideration for everyone who is, coming on for care initially. I don't know if this was initially felt to be operable or not. It looked like it, perhaps, from looking at the images, but we don't have the full images. I am. If we have an obviously operable and with, of course, good liver function, whether cirrhotic or not, is my first, as long as transplant is not into consideration here, my bias is for surgery first. And unless it's something that the surgeon would like to kind of downstage use it for whatever reason, to have a better surgical margin, or to make an inoperable, potentially operable, then we of course look at the adjuvant therapies. Now, the question of immunotherapy, and I'm pretty sure Ghassan will also elaborate on that, is that you can see some decent deep responses. Unfortunately, they don't happen in everyone. So local regional therapy may still be, for me, an option if doable. Again, it's a case-by-case basis. I've seen some cases with immunotherapy where the patient had even a venous or tumor in vein invasion, and they respond very well to the point that they can be considered for surgery, and that is not something that you would necessarily have with TACE, for instance.
So maybe the question for the
clarify
surgeon.
something. This was initially multifocal, right? There was a satellite lesion.
Yes.
So Bassam, you consider that operable, multifocal disease?
It depends on where it is. I mean, I think I understand that you have to, when you have something big like this, to understand the biology of the cancer and to make sure that it is not something that is a little bit more aggressive than what is seen. So yes, if it is a multifocal, I lean a little bit more toward preoperative therapy, just to make sure that you're not missing out on any either metastatic disease development or other foci in the liver, like what may have happened with this gentleman.
But in this case, at the time of the presentation, it didn't appear that there was multifocality. It appeared there was just one single lesion, correct?
Yes.
Okay, my fault. I thought you said there was a satellite. Sorry.
On the final pathology, yes.
On the final pathology, right?
I think in this kind of case, the liver looked okay on the scan. And in Sinai, we do see a lot of patients, we integrated with the transplant program. We would have entertained radioembolization as a lobectomy. So it kind of gives an advantage of taking care of the tumor at the same time, having the hypertrophy on the left lobe. And we just finished our trial on immunotherapy. In the interim, when patient is waiting 3 months or few weeks for hypertrophy, and with the tumor in control, we would have put the patient on trial with immunotherapy, which has some added advantage, and would have let time tell us whether this is a good surgical candidate or not. That's probably the approach we would have taken in Sinai.
So we were just talking about a tumor board with Bassam. So you guys actually utilizing simultaneously in this, you mentioned radioembolization and immunotherapy, correct? Yeah, immunotherapy is pretty well tolerated. We're not talking about combination. We're just talking about PD-1 inhibitors, which is pretty well tolerated. This is an advanced case, but we even did the trial on resectable hepatocellular carcinoma, knowing the nature of the disease that these patients always recur. It gives us an opportunity to know whether these tumors for the particular patient is responsive to immunotherapy or not. Because once you do immunotherapy and then we resect them, we know, we do examine in the trial, we did examine the pathology and see how many of them responded to immunotherapy or not. Interestingly, about 35 to 50% had good response to immunotherapy. These are resectable cases. In this case, the cases which is advanced, we have definitely used immunotherapy during the time we are waiting for resection. Right. I mean, I agree overall with Bassam's statements on the fact that if the patient presents with resectable disease and hepatocellular carcinoma, we would do that. But I also believe that there is a role for this initial intervention to sort of unveil the tumor biology, right? You want to see how the tumor responds to the therapy, number one, and number two, if there's no progression, right? No appearance of additional disease before you take him for a big operation, especially in an older patient like this, I think 70-some. So I think it's something very reasonable to consider. Now, I have a question about the biopsy, Renuka. Where was it done? We typically don't biopsy HCCs if they meet, radiological criterion. In this case, didn't appear there was frankly cirrhotic, but no obvious evidence of background of liver disease like hepatitis B or C. So any comments on that?
Yes, this person already came to us with the biopsy.
Okay.
So.
Okay.
But most of the trials also need biopsy. If you're putting a patient on a trial, they probably want diagnosis before they put them on trial. That's another reason.
Sure. So, Renuka, let me go back to your main question. I, number one, concur, and I think Bassam said it nicely, is that by all means, we always support clinical trials. Because number one, I think you brought in 2 points, which are critical. Number one, is it neoadjuvant therapy? And if so, what type of neoadjuvant therapy? Number one is, and I think Mike brought in a very important perspective, if there was theoretically a added lesion, let's say resectability, in other words, as was thought of, was really in question. We have to remember that neoadjuvant is not conversion. Neoadjuvant means it's resectable right now. I'm simply trying to control the biology of it to ensure that I can reduce on the recurrence potential. Patients will tolerate therapy more before surgery than after surgery. They'll get more of the therapy before surgery, after surgery. Conversion therapy, it implies that I'm trying to really turn it into resectable because currently it's unresectable. Intriguingly, both concepts are not validated yet in HCC. And in other words, really, this is really where the trials, and that's why it's nice the patient was on a study to really consider for a neoadjuvant approach or conversion approach. Now, the second point though, let's assume that we are to really study the approach for neoadjuvant therapy. No question that the checkpoint inhibitors are going to be a critical component. Now, how are we going to embed it within? Is it with a TACE? Is it with like single agent, or is it a combination of? This is, of course, up to a lot of interaction and discussion that might occur. But as you know, we are doing at the moment in the adjuvant setting checkpoint inhibitors, because ironically, when the first sponsor of checkpoint inhibitors came to us literally almost 15 years ago, our answer was definitely try it after embolization. And because really where the environment will be at most enhancing for that purpose. So know that clinical trials are decent, but at the same time, short of clinical trial, we cannot justify a neoadjuvant or conversion. And number two, we cannot justify even a choice of because we don't have the data. In regard to the biopsy, to second what Ganesh said, yes, in trials we require biopsy, but also we require biopsy even without trials. The way I understand it, I like very much the way actually Renuka said it. The radiologist implied LIRAD 5. We entrust that language, and this is really what the radiologists talk to each other about. Actually, our radiologists, who were heavily involved, actually, they wrote the LIRAD. I asked them, like, what exactly is LIRAD? It's technically, it's a language for the radiologists to talk to each other. If any of us really is ready to sign, like, that's the HCC until proven otherwise, even for LIRAD 5, we're going to have a little bit of an issue there, because combination of, and you're going to come to that maybe in your second case, cholangiocarcinoma plus HCC, other variables are going to be very important to really dissect in a biopsy. And that biopsy is needed also for that purpose. We really need to understand if there's any potential for targets in the future that patient might use. We know very well that FGF19, FGF4, FGF2 can happen in HCC. And as such, this if we don't do the biopsy, we'll never learn more, and we'll never also offer potential therapies for the patients. So actually, any patient who gets systemic therapy by definition should get a biopsy, or at least have tissue from prior surgery before we proceed with any therapy of that nature.
So Ghassan, in your practice, you're routinely biopsying with HCCs?
150%.
But Federico, to be fair, Ghassan is seeing advanced disease. He's not seeing early stage disease.
Yeah, correct. But we have a lot of interaction where, for example, Michael would know that if there's biopsy, we'll send for the tissue to be analyzed for whatever added nurse purposes. Our IR colleagues, if they were to do a embolization, we understand biopsy is not necessarily critically needed, but they will get the biopsy at the same intervention. So we'll always make sure that we get tissue in any opportunity we can. But for systemic disease, 100% we get tissue by all means to verify.
Got it. And, I have a question about the adjuvant setting after resection. Do we have any data on any trials ongoing on that? Nothing yet?
So there are a few studies going on right now in regards to immunotherapy in the adjuvant setting after resection or ablation. These are ongoing trials, but we do not have any data yet. The only data we have is from the space from sorafenib in the adjuvant setting, which was not really, did not have any effect on overall survival or other metrics. But I think there is an interest, more interest in the immunotherapy realm right now, by itself or in combination with something like bevacizumab. So there are ongoing trials of these, and I'm sure many of the major centers are participating in those.
I do concur with what Ghassan is saying, and if anything, the adjuvant therapy for tyrosine kinase inhibitors, which was validated, which was tested using sorafenib, did not work exactly as Bassam said. And if anything, the reason it didn't work because the tyrosine kinase inhibition is not really of any important validation or activation after surgery. Intriguingly, checkpoint inhibitors will have more value. I would say we have studies currently ongoing. Some of them already completed accrual for checkpoint inhibitors, but we probably would not be surprised to see exactly as I'm saying, a combination of. I would say though, maybe it's not going to be atezolizumab, bevacizumab, even though it's being evaluated. I would definitely say that we'll kind of, feel a little bit nerved up with the bevacizumab after surgery, something to really think about in that regard. But it will be nice to see what the study will show up anyway. But it will not be surprising. It might end up being a combination per se, rather than just a single agent or a simple approach being TKI, which already, as we said, is negative, or a checkpoint inhibitor. So
I should just also add that for the hepatitis B populations, giving adjuvant therapy with antivirals has been shown to be effective, and that's not the focus today, but just something to note for the Hep B patients that we don't see that much of here. And then as we get ready to move on to the next case, any comments from the surgeons? We are now offering all these checkpoint inhibitors and seeing some major responses. Are there any preoperative findings that would make you feel, even with the major response, that surgery may not have a role? Have you pushed the envelope yet on patients that were multifocal or even with vascular invasion to push for surgery if they've had a big response?
Yeah, I mean, we're starting to consider these cases that, present with very advanced disease, and we're seeing these very drastic responses to immunotherapy. So like, for instance, earlier we were reviewing a patient for transplantation. We decided to wait a few more months to see if it remains stable to consider that. But I am sure that we're going to, start seeing expansion of the role of surgery that we were not applying before, and these very good responses to immunotherapy. And I wanted to ask you guys also, is there any predictors of response to immunotherapy, any biomarkers that we have discovered, any of the studies that have been conducted?
So the answer is no, but however, definitely this is a great question because this is something that we have a lot of interest in, Federico. If anything, at the moment, the work that we're doing is to analyze the tumor immune microenvironment to really try to predict not only who would respond, but to exactly what they will respond. Because no doubt that the previous understanding that we had is that Hep B, Hep C, NASH, alcohol as different etiologies imply different disease, i.e. we call it all HCC, but probably it's not the same. And we tried different ways with systemic therapies to find out if really people fare better with one versus the other. And so far, we don't have 100% validation. We are still giving therapy independent whom we're giving it to. But interestingly, the tumor immune microenvironment and components of it like CD4, CD8, FOXP3, PD1, PD-L1, and maybe hepatitis as well might play roles. This is something that we're currently working on and like will take us. But with this said, a very important question, and I'm sure probably Renuka is going to ask it. I would say this is great for this patient. And after a long period of time, free of disease, that's quite impressive. But I personally would say, not to kind of disappoint anybody, but this is an outlier. This is not the standard. Because from my standpoint, for somebody who has metastatic disease, to go after every pinpoint metastatic site and try to do a local therapy is not the appropriate approach, because this is really will stand totally against the angiogenic drive that really will make the disease worse. And this is exactly what probably could have happened after the first embolization or the intervention at the recurrence, because he erupted with a lung lesion per se. He's lucky, he did very well. Of course, we're happy for, but I would say this is systemic therapy by definition. The group of Michael, here at Memorial, this was published, I believe, Michael, like almost 20 years ago. By definition, recurrent disease after surgery, even in the liver, is stage 4 disease. And there's really what has to be perceived in regard to outcomes. So systemic therapy, especially with the advent of so many great therapies, will be the right way to go, not to really go and pinpoint one of the lesion after the other. This is very important for our audience to really see this as a outlier, not the norm, because otherwise we're going to give a wrong message that we have to go and pinpoint things wherever they spread out. It's systemic therapy, the answer.
Couldn't agree more. This is what we call a numerator case.
Correct.
In other words, one in many.
Thank you. So with that, I'll try to move on to the cholangiocarcinoma case, and we'll try to go through that a little quickly. This is a 69-year-old Caucasian lady with this past medical history. And she had a workup actually for hematuria, and they incidentally saw a solid lesion in the inferomedial right lobe of the liver, approximately 6.5 or so centimeters. That was very suspicious. No other pathology, no lymph nodes. And as we do for liver lesions, we had upper and lower scopes to rule out any other primary tumor. And this, let me just get to her scans. And these are her baseline scans. We basically saw a large heterogeneous enhancing bilobar mass with overlying capsular retraction compatible with cholangiocarcinoma. The mass extended centrally, and it approximates the portal vein, as you can see. So in lieu of this, she was discussed at conference, and they asked if we had anything to offer systemic therapy-wise. And at the time, we gave her gemcitabine and cisplatin, and we can talk about what we would do today if she was presenting with the same presentation. And she got that for about 4 months, following which she had restaging scans, and it showed that the tumor had responded a little bit, and the post-therapy images showed a reduction in the size as well as enhancement of this mass. The surgeon who was looking at it felt that there might be some outlet obstruction, gastric outlet obstruction. So she also had this EGD. And while they were there, they looked to make sure there were no lymph nodes that were concerning. She then had a portal vein embolization. So this is the imaging post neoadjuvant chemotherapy. And following that, she had an extended right hepatectomy, including segments 4A, portion of 4B, and a biopsy of a solitary peritoneal nodule that ended up being nothing. She went home, and following her recovery, she saw the med-onc folks who felt she should get some adjuvant chemotherapy, and got 2 months of Xeloda, tolerated it quite well. And this is what the final pathology showed. A cholangiocarcinoma with some treatment-related changes, 7.2 centimeters, resection margins negative, grade 2. And on surveillance, following her adjuvant therapy, she unfortunately demonstrated a recurrence, a 2.2 centimeter mass abutting the surgical margin. And this was very concerning. A biopsy of this was done, and we can discuss whether everyone would biopsy this or not. And after appropriate workup, she underwent an open left hepatectomy. Wow. And did quite well. She stayed in the hospital for quite some time. And you can see the final pathology did confirm this was a recurrent cholangio. They had to go back and take another margin because it was a 0.1 centimeter close margin. And she didn't have any further adjuvant therapy. And now it's about 3 years out. She's doing quite well. So this case brings up the question of the choice of neoadjuvant therapy in this particular patient. And maybe I'll pick on Bassam here. What has your experience been with GemCis or anything else that you would offer?
Well, I will be an outlier because I actually don't like GemCis. I'm a more, you know, when I use systemic therapy for either locally advanced or I usually use gemcitabine and oxaliplatin. Is there a reason why? Is it better than GemCis? No, I think I have seen better, maybe tolerance with it. The effects, I would say, the same, but that's my bias. There's a little bit more. I haven't gotten into trying something a little bit more extensive, like adding Abraxane or nab-paclitaxel to this. So that's what I would what I'm doing right now. Of course, in any case like this, like Ghassan mentioned earlier, for hepatocellular carcinoma, getting a biopsy, you want to test for whether they have FGFR2 or IDH1 or any of the mutations that are available, and see if they're eligible for clinical trial or off clinical trial. There are some nice responses with pemigatinib, for instance. Even the second line, we shouldn't be a reason why it can't be in the first line too. We don't normally use that off label, but and these are very few cases. I don't know what Ghassan does in his practice as far as systemic therapy, but that's where I am right now.
So thanks so much again, and thanks Bassam, thanks Haruka. So again, 2 points over here. Number one more time I stress, neoadjuvant and conversion are totally different stories, and it's very important to really delineate. If this is not resectable, this is conversion, and it's very important because it's very critical to really understand that this, if not to succeed, how we're going to evolve with further systemic therapy. Number two is, you know, actually Alice and Mike and, you know, even, you know, Dr. Brennan, we all have discussed that, and no doubt we do acknowledge that adjuvant therapy does not work in that disease. And if anything, it's all about what we're going to call peri-adjuvant, i.e. therapy before and after surgery. Now, in regard to the choices, I think, Bassam, your opinion in regard to GemCis is more of a personal opinion, because I don't think really we're in a position to say like or I don't. If anything, really, we favor cisplatin in a position like this, and that's why I go back to the conversion, because presumably if it's conversion, it means it's systemic disease, i.e. I'll give it GemCis with the presumption if it turns around to be not the case, then I can go for surgery. And as such, the best data available so far is from GEM-CIS. And intriguingly, we like GEM-CIS and we don't favor oxaliplatin for the following reason. Do we have in our clinics patients on cisplatin for a year and a half, for close to 2 years? Yes, we do. Interesting, you'll never be able to do that with oxaliplatin because the cumulative effect will really kind of, max you out at 800 to 1000 milligram per square and you're done. While with the cisplatin at many doses of like 20 milligram per square, 2 weeks, 1 week off, can really take a long mileage for patients. So it's really important to really not think about what we're going to do right now, but really think about how we're going to keep the patient going for the longest duration of time. So.
Wonderful. Ganesh, your thoughts? Is this the surgical approach you would take, portal vein embolization, 4 months? Do you have a preference of optimal neoadjuvant or conversion pre-op therapy?
In terms of cholangiocarcinoma, it's a surgical disease. I don't think we have enough evidence to support that chemotherapy or other treatments really worked in terms of cure and long-term survival. So this approach, what we took, is very reasonable, and it looks like the patient did really well. Re-resection for cholangiocarcinoma has been well established, and I think patients who undergo re-resection do pretty well. And we have many patients who survive 5 years and above after re-resections. So if you can resect, we should resect cholangiocarcinoma, obviously safely. And the role of adjuvant treatment, I think currently we are talking about IDH mutations and FGFR mutations, and hopefully they could help us to give a longer survival after resections.
So thank you guys. This has been great. I would say, to close this session, definitely this was another outlier. I personally would have not re-resect. I would consider that if the timeline between the first resection and the recurrence is really prolonged, and in terms of more than a year, for example. But otherwise, probably would have considered radiation and systemic. But very happy for this patient who did very, very well. So thank you guys. It's been great. We're gonna move on. Otherwise, we're gonna run out of time, and we're gonna get into the last session of the program today. And this will be about rare indication for liver resection, the South American experience, and Dr. Leandro Mosna, who is a friend and colleague from Argentina, who trained here in HPB and liver transplant in New York and in Miami, is going to talk about resection for hepatic idiopathic cyst. And as panelists, we have, I think Dr. De Souza Fernandez was in a plane, so we won't have him, unfortunately. We say hi to him, but we have Dr. Martin Div from Pontificia Catholic University from Chile, Santiago, and Dr. Juan Pejol from the Italian hospital from Buenos Aires to join as panelists. So thank you so much, guys. Leandro, you're on.
Hi, Federico. Thank you very much for the invitation to the International Relations Committee of the HPBA, and you, especially to you. And I was asked to present a liver case with a rare indication for liver resection. So I thought maybe hepatic hydatid cyst is pretty much rare over there. It's not rare here in Latin America, but let's see. Okay, this is a 55-year-old male from Patagonia, Argentina. For those who don't know, Patagonia is like half, if you make a line, the half of our country. The south part is the region called Patagonia. He was a rural area farm worker, presenting with chronic right upper quadrant pain. Laboratory, liver enzyme slightly elevated, alkaline phosphatase 100, and total bilirubin 1.2 milligrams. We did a serology. IgG was reactive for high doses. The ultrasound showed 17 centimeter cystic mass involved in the right liver, and then the CT scan showed the right mass with heterogeneous content and thick wall. I don't have a video, but I have picture here, we can see the big cyst taking almost all the right lobe with heterogeneous content and a sick wall. So how we manage this case? We started with albendazole 50 milligrams per kilo day, be orally during a month. And then we planned this, after that month, we planned the surgery. We did a liver resection, non-anatomical. I'm gonna show the video. Everything went okay, discharged at postoperative day 5. And after the surgery, we continued with the albendazole treatment, same dose, during the 2 months. The video, I'm gonna share the video, excuse me. It's not on the, excuse me.
Pedime guante.
Okay, can you see it?
Yes, perfect.
Okay, this is open approach, right subcostal incision. As soon as we enter the cavity, we saw the big cyst. First of all, that's dissection from the retroperitoneum, cutting the adhesions. We are now separating the cyst, the pericystic, from the diaphragm. Sometimes there is a nice plane and sometimes not. The inflammation of the cyst tends to make very sticky adhesions, strong adhesions. So we are taking down the triangular ligament, the right triangular ligament there. We found a plane. If someone of the panelists want to comment, that's a hole on the diaphragm I'm going to show you later. So we are dissecting the lateral aspect of the vena cava, separating the tissue from the cyst.
So Leandro, any measures in general in these cases to, prevent spillage,
Yes,
contaminate the field?
It's a key point. That's a hole. It's not uncommon because the inflammation, the cysts are aggressive and sometimes it tends to go to the thorax. So we put a stitch there and we suck the air to minimize the pneumothorax. So yes, it's a key point to avoid the spillage, because if spillage occurs, dissemination can be very, very bad. So this is a closed technique. So we didn't open the cyst, but still the field is isolated with gauze. Some surgeons use scolicidal agents, moist gauze with hypertonic saline, basically. So we are doing like a piggyback, ligating and dividing the hepatic veins to mobilize the complete cyst from the cava.
Leandro, is this non-anatomical resection or is this
yeah. The thing is, we plan at the beginning with the images. We thought that maybe it's gonna be right hepatectomy, anatomical, but then we spare basically a segment 5. That's the right hepatic. We divided, the right hepatic went directly into the cyst.
But the plan was not a pericystectomy, a total pericystectomy?
Initial plan was maybe was liver resection. We didn't have an initial plan, so we're gonna see when we mark the parenchyma was a liver resection. But then I want to show you, during the parenchymal dissection, we passed from the healthy parenchyma to the cystic plane. So that's the dissection of the hilum. We encircled and the right portal and ligated the right hepatic artery.
Leandro, you didn't decompress the cyst before during the surgery to make easier the management of the liver?
No, we didn't touch the cyst. We didn't puncture. We leave it alone.
So how would you do that? You suction the content you did before the surgery percutaneously?
Yes, there are open techniques and closed techniques. This is a totally closed technique. So now this is separating the cyst. That is the pericystic from the anterior aspect of the cava, obtaining a total mobilization. Some of the hepatic veins remaining. I'm going to continue towards the middle hepatic vein that we saw that it was also compromised by the cyst. That's middle hepatic vein.
So you didn't ligated the right portal. You took the right hepatic artery.
No, the right portal we ligated the intraparenchymatous. We ligated the right artery.
Do you often take the right hepatic vein before you take the inflow, or is this the right hepatic vein?
The right portal is not taken.
I always take the inflow before doing the right hepatic vein because the liver gets congested. I'm just curious.
No, I think Mike, they took the right artery, the hilum, and they took the right pedicle portal, pedicle intraparenchymally.
Not yet, though.
But I don't know if yeah, it didn't.
In my experience, you get a very congested posterior sector.
Right,
Anyway.
but so I assume you were pringling when you were doing this.
No, because we had taken down the artery and we have encircled. Yes, maybe a right Pringle, you could say. No, not the Pringle.
But you had the right portal vein encircled.
Yeah, encircled. Yes.
Oh, I see.
So that's the parenchymatous transection through that's what I said before. We started doing by healthy parenchyma, and then we try to spare, and we go directly to the pericystic plane, but still it's a liver resection.
Leandro, may I ask you?
Yes, of course.
So in Chile we have a different approach in general, but my question to you is, when do you use a closed technique and not to aspirate and control it versus just controlling it, aspirating it, putting hypertonic saline, and so that way it doesn't get spillage.
Yeah, that was
in the middle of the mobilization. I wonder, like, if you choose some cases that you do closed and some open. In general, that's done, in the latter way here.
We prefer to do, if we can do it, we prefer pericystectomies, total closed pericystectomy. Sometimes we cannot do it. When we cannot do it, we have either a subtotal pericystectomy or maybe a MAVI techniques, but we try always to do a closed pericystectomy by That's the piece. And that's the classical content. Okay, I'm gonna close this and continue. Okay, some of the panelists, I know you guys would have done something different. What would you have done?
Yeah. Martin asked something interesting, and is when we are using the close or when we use the open technique. And I think that this is related with the size of the cyst. And probably in the big cyst, I prefer to do the open approach to aspirate. And for this reason, we are giving to the patient at least 1 month before surgery albendazole, trying to kill as much as possible the parasite, and that we have less possibilities with the spillage. If we have a small cyst, this is the easier to do the close technique. And I think that the treatment of idiatic disease changed a lot with the employment of liver resections. So we are using now very often pericystectomy. We directly prefer to do a non-anatomical resection using 1 or 2 centimeters of normal parenchyma. I think that this was the best news for the idiatic disease. The problem that this technique are employed in reference centers and not in the rural centers where is the disease. In the rural centers, the people prefer to do conservative treatment. We are in the Buenos Aires, we are not in an endemic area, and we receive very complicated cysts with calcification, and we use more frequently liver resections.
Good. Yes, I was going to say something about that, Juan. It's very important. This distribution of the disease you see on your left, the map, the world distribution. We, Argentina, and the places in dark red are high endemic areas. You guys in North America are very sporadic or rare. On your right, you have a map of Argentina, our country. We are in Buenos Aires, and the red zone is Patagonia, what I told you the patient was. This is a parasitic infection, you know, produced by Echinococcus granulosus. There is a cycle. Basically, there are definitive hosts that are dogs or fox, and the intermediate hosts are cattle, basically sheep, but can be pigs and cows. And the human gets in the middle of the cycle, and when the human get in contact, in touch with dogs, or eat vegetables, can get the cyst. So basically, there is a single organ involvement in 85% of the cases. Liver is the main organ affected, up to 70%, and then second place, the lungs. Right hepatic lobe, as I show you, is the most frequently affected. Solitary cysts are in 70% of the cases. 1/3 of these patients can have complications, being the most frequent, the biliary communication that can produce cholangitis. For the diagnosis, we have serological tests. The most used nowadays are serology, ELISA, and then the confirmation comes with Western blot. But still, the ultrasound remains the very important for diagnosis. It's a very important tool for screening. You all guys know the Garvey classification, still is in use from 1981, and then in 2003, the World Health Organization made a very, very similar classification. Garvey type 1 as a cyst without anything in the interior. Garvey type 2 is the water lily sign, is a cyst with a detached membrane. Garvey type 3 is the classical with daughter vesicles, and type 4 heterogeneous, and 5 calcified cyst. And then, of course, for confirmation or for surgical planning, we always do a CT or MRI.
And what do you guys think about MRCP or ERCP to see if there's any connection with the major bile duct structure, biliary structure?
Yes.
Is that?
That's a good question. I mean, if we suspect that some part of the parasite, there is a biliary communication between the cyst and the bile duct, and there is occupying parasite in the bile duct, we because of the images or labs or symptoms, ERCP is a good thing to do. I don't know, Juan or
Yeah, so in Chile, I think that things are done a little bit different. I actually did my whole surgical training in the States and Toronto, and so I came back here, and I've been really impressed by the management of hydatid cysts here. Most of the hydatid cysts here are done with perisystectomy. And most of them laparoscopically, actually. I think, you know, the radical surgery for hydatid cyst, either surgical resection or perisystectomy, have very good outcomes. You know, there are a few published series from here, and even minimally invasive. And I think part of it is that it decreases the cyst recurrence and the morbidity of continuing, you know, having the cyst recur or get infected with the conservative approach. And so I am really convinced that that radical surgery is better. But in terms of surgical resection versus perisystectomy, I think perisystectomy, it's less of an operation. And you're able to have more than 90%, most of the times, more than 90% of the cyst resected without necessarily going into the actual liver parenchyma. And that way you decrease bile leaks of all this liver parenchyma that may be compressed by the cyst, and then after you take it out, it may get decompressed, and then you have bile leaks. And I think that in terms of the spillage, most of the times here, what is done is to drain it in a controlled manner, even if it's laparoscopically. I think either lap or open, the concept is to decrease spillage. So instead of mobilizing it closed, the idea is to drain it in a controlled manner with gauzes with hypertonic saline, aspirate it, then put hypertonic saline, leave it for 5 minutes, aspirate it again, and then take the cyst out in that plane between the cyst and the parenchyma.
Okay, thank you. So, well, we have been talking about this. The surgical treatment, the goals is eliminate the parasite, prevent the spillage, and therefore the recurrence. So the thing is between conservative approach or radical approach. And then you can do either both. You can do laparoscopic too. So conservative approach, remove the cystic content but leave the perisystic membrane. Martin explained about that. You can puncture, aspirate content, instillate scolicidal, hypertonic saline, and then do a partial resection of the wall. It's simple, can be done, as Juan said, in a rural hospital, no high complexity center, and can be done by general surgeon, no need for a HPB surgeon. But this procedure has a higher recurrence. The radical approach needs more complexity, and maybe if you do a liver resection, you're gonna need a HPB surgeon trained, and it's better to perform in a high complexity center. The advantage are that the recurrence are lower. Here I have some pictures of a conservative approach. the cyst is open, the content is removed, and then you can see on the left side the installation of scolycidal agent, and then the resection of the wall, and that's it. It's very simple. Again, conservative aspiration of the content, removal and resection of the wall, and you can see a biliary communication that with the simple stitch, of course, you have to do a cholangiogram, it's resolved. And then here I have some pictures of radical, the pericystectomy. This is the case segment 5-6 of the liver. This is open approach, of course. It's a closed pericystectomy. So you go through the plane, inflammatory plane between the liver and the cyst. Another pericystectomy, same thing. And regarding the laparoscopic approach, we do laparoscopic approach. We selected the case. We don't have, I mean, we have more experience in open, but we do sometimes laparoscopic approach. This is a closed pericystectomy laparoscopic approach. Of course, always preventing the spillage, very important thing, and taking the specimen out in a bag, of course. Regarding the laparoscopic approach, if you go 20 years ago, there were a lot of criteria to do it, like a unique cyst, anterior segment, less than 7 centimeters, no infection, and avoid opening. Nowadays, things change, and it's basically depends on the surgeon training and the center experience. Basically, if you can do it, you are trained. And in laparoscopic liver surgery, there is no limits. You can aspirate, open the cyst as long as you prevent the spillage. Finally, this is related what Juan said. This is experience in Argentina rural center in the city of Esquel is in Patagonia. This is a high volume but low complexity center. They don't have HPB surgeons. They don't even, I think they don't even have argon beam coagulator. So it's an hyperendemic area. This is a paper presented in a local meeting in year 2010. And they have a big volume, almost 1,500 patients between 1984 and 2009. Basically, what I want to show you is more than 70% of the cases, they perform conservative approach with the MAVIT technique, and they show that they reach very good results with a recurrence of 8% and complication of 13%. So this can be done in a rural place, and if even if there is not HPB surgeon, so conservative approach is very useful.
Now, obviously, Leandro, obviously, if you do the conservative approach, you expect to have higher recurrence rates, right?
Yes, recurrence in conservative approach, I read is up to 20% sometimes, 15-20%.
I have a question about the recurrence. I always find it very hard to assess. Like, how do you know they have recurrent disease if you do a conservative approach? They have a fluid collection. They're going to have a little area there, and their markers may still be high. Their serology may remain high. So, is it a true recurrence or is it an artifact from prior recurrence, from prior disease?
Basically, the recurrence is diagnosed by images.
But they're gonna, if you do a conservative approach, you expect to have a cavity.
Yeah, you have cavity, but you expect not to have after a couple of months. So you have a residual cavity. You should treat sometimes the residual cavity. You can do omentoplasty. You can fulgurate the cavity, but you can have an abscess if the cavity gets infected. But you shouldn't have a new cyst, and if you have a new cyst, it's going to be months later, and you will see by images.
I mean, I would just say that I do find it just difficult. I mean, we did a conservative approach for years and years, and I didn't ever see a clinically significant recurrence. We did see a cavity, and I think sometimes it's called recurrence by people who may not understand what was previously done with the patient. So I just wonder if that's something you guys struggle with.
Yeah, so That was a great presentation, Leandro. And I think what Leandro says, that it depends on where you are, I think that's really important. What are the resources you have? You know, I've done a conservative approach in North America, but here in Chile, that in the endemic areas, basically most of the hydatid cysts are treated with a pericystectomy or resection, like radical surgery. And the morbidity of that is about 16%. So if you think about it, you know, the morbidity of this operation is low enough that, because you say, okay, the recurrence rate is 20%, you could say, but you don't know how much these patients, how much follow-up they will have. And if you're gonna already operate on them and you're gonna have a low morbidity operation without recurrence, I think it's worth it. I think it makes sense to me, and it made sense to me when I arrived here. I think it may be better than the conservative approach.
So that's really great. I have a final question. The length of anti-helminthic medication after surgery, does it change based on the surgical technique you utilize? For how long you go?
We use the 1 month before and 2 months after, but it depends on the center. I mean, it's not a rule. I don't know, Martina, Juan, what do they use? How is the dose or whatever? But as long as you do 3 months total, it's okay.
Got it. All right, guys. Well, we have to wrap up because we ran out of time. I really wanted to thank you all, the panelists, the speakers, the audience. This was fantastic. You guys are great. I really hope I see you all in August in Miami, HPBA. Thank you so much. Really appreciate it.
Thanks, everyone.
Thank you.